So today we'll be discussing a very important topic, and that is all about serum creatinine. Now we very commonly see that serum creatinine, this is the blood test which is very commonly done. Now what is the importance of the creatinine? Creatinine simply reflects kidney. So one of the most important thing which we use this creatinine is for is to calculate the creatinine clearance. So what does this mean is this is simply we can say okay, this is the estimated glomerular filtration rate. It means how much the kidney is capable of filtering the blood so that it can produce the urine. It is as simple as that. So this creatinine clearance, we have a very good formula, which is 140 minus H. This has to be in the bracket into weight in kilograms divided by 72 into creatinine. So this is the number that we usually get. And if the patient is female, we have to multiply it by 0.85. So now this creatinine clearance, or so-called estimated glomerular filtration rate, is very important because there are so many drugs which needs dose adjustment if the creatinine clearance is less. For example, like piperacillin, tazobactam, nitrofurantoin, meropenem, levofloxacin, amikacin, diclofenac, and there are so many medicines which need to be adjusted as per the creatinine clearance. So calculation of this creatinine clearance is very necessary. Now normally we say the creatinine clearance is more than 90 ml per minute. So this is the normal creatinine clearance. So all of us, we have this creatinine clearance of more than 90 ml per minute. So it is called normal, and we label that the patient is in stage A. So this is the staging as per the creatinine clearance. This is the staging of everybody to label whether the patient is in CKD 1, that is chronic kidney disease 1, 2, 3, 4, or 5. So if the creatinine clearance is very less, if it is less than 15 ml per minute per this 1.73 meter square, we say that the patient is in end stage renal disease. It means the kidney is so much damaged so that it is very common to see that that kidney starts giving so many problems. So less than 15 ml per minute, we call it as end stage renal disease. When this creatinine clearance number, which we have already calculated, comes in between 15 to 29, we call it as the kidney is extensively damaged, the kidney function is severely decreased. When this number is between 30 to 60, we call it as the kidney is extensively damaged, but the functioning of the kidney, we say it is like mild to moderately reduced. 60 to 90, we call it as the kidney function is mildly reduced, and we need to be very careful to make sure that the kidney survives, kidney gets better, and kidney doesn't get damaged over a period of time, for which whatever underlying faults are there, like hypertension, diabetes, smoking, alcohol, poor lifestyle, cancers, whatever the disease is there, which is actually causing damage to the kidney, we have to treat. So this is the staging of the kidney from stage 1, 2, 3A, 3B, 4, and 5. And this 5 stage 5 is called end stage renal disease, which is one of the indication for initiation of hemodialysis. So what does this increased creatinine means? This increased creatinine means, as we know, the the creatinine usually normally remains around 1 milligram per deciliter. So when we calculate the creatinine clearance, we get the number, and most of the patients or most of the people do have creatinine clearance of 90 ml per minute. It means that the kidney is able to filter 90 ml per minute of blood. So as the disease advances, if the kidney is in stage 5, so kidney is able to filter only suppose 10 ml or 11 ml of blood per minute. So if the filtering capacity of the kidney is so much reduced, then how can urine be produced? To produce urine output or to produce urine, the kidney has to filter a larger amount of blood. If the kidney is able to filter very lesser amount of blood, automatically the urine output will reduce, because urine is all produced from blood itself. So lesser and lesser and lesser is the blood filtration done. Automatically the urine output will start in reducing. Other things which we need to see, so as the creatinine clearance worsen, the capacity of the kidney to filter more and more urine will reduce, so automatically the urine output will reduce. This is the first thing. Second thing, we label it as the patient has oliguria if the urine output is less than 400 ml per 24 hours, and we label the patient that the patient has anuria or complete renal failure if the urine output is less than 100 ml per 24 hours. Now, what are the problems with this creatinine? Why we are so much worried? Because we simply must know the kidney is filtering blood, means what exactly it is doing? It is producing urine. Why it is producing urine? Because it has to excrete the abnormal bad things in the blood. One of the most important is this potassium. So the excess potassium it has to filter. So if kidney fails to produce urine output, it means kidney will fail to excrete this potassium. So if the potassium excretion fails, automatically there will be building of this potassium in the blood, which we call it as hyperkalemia. And hyperkalemia is one of the most common cause of sudden cardiac death in patients with CKD. We very clearly know if serum potassium is between 6 to 7, we get tall, peaking, symmetrical, tented T waves, which I have shown in multiple of my videos in my YouTube channel. If the potassium is between 7 to 8, there will be loss of P wave. P wave get lost, and the QRS gets widened. If the potassium is between 8 to 10, patient may anytime have VT, VFib, or O-systole. This is very important. And when the potassium is more than 9, the patient may anytime have sine wave pattern. Sine wave pattern is like this. So we will not get any P wave QRS. We will simply get this type of thing on the monitor. It means the heart is not at all pumping and the patient will die. So this potassium has to be corrected very fast. And whenever there is this rise in serum creatinine, we always have to see what is the level of serum potassium in the blood, which is extremely necessary. Then the fourth thing is we see the patient may have metabolic acidemia. As there is increase in serum creatinine, I simply told, whenever kidney produces urine, what it does, it excretes the nitrogenous products, means these are, it excretes the waste products. It also has significant role in acid-base balance. So the blood pH, which is strictly maintained from 7.35 to 7.45, so it excretes the acid so that this balance is strictly maintained. But in because there is rise in creatinine, that is because of the kidney failure, the kidney will not excrete this acid, so automatically there will be increase in acid levels in the blood, which we call it as acidemia. So patient very commonly have metabolic acidemia. That is the reason why most of the time we give this Sobosis tablet or Sobosis 4 tablet twice a day, thrice a day to take care of this metabolic acidemia. And acidemia is very bad because I have told so many times, acidemia has some very bad things. Acidemia very commonly cause hypotension. Acidemia very commonly increase the risk of arrhythmia. Acidemia very commonly causes tachypnea, tachycardia, and acidemia is one of the reasons why the inotropes or vasopressor doesn't respond well until the acidemia is corrected. So acidemia also causes cachexia. So acidemia is very bad, and acidemia is one of the most common reason why CKD patients do need dialysis. The third thing is anemia. Now, whenever there is increase in serum creatinine, means there is kidney failure. So, uh, there will be building of so much chemicals, because what kidney has to do is excrete to remove all these toxic products like nitrogen waste product, acid, so many chemicals. Kidney fails to do so. This blood is filled with so much of bad chemicals, and these RBCs are actually floating or moving through the same blood. So these RBCs get exposed to so many bad chemicals. That is the reason why the RBC's lifespan is reduced. That is the reason why patients very commonly have anemia. Other reasons, because of the CKD, because of the multiple issues, because of the inflammation, they have reduced appetite. Because of the so many hospitalization, they don't get proper food, so they are malnourished. They do get poor nutrition. These are the reason for anemia. Because of the multiple blood tests, the blood is drawn every time, like 5 ml, 10 ml, for testing of the blood. So multiple times removing of the blood, malnourishment, reduced appetite, hospitalization, medicines, this all cause anemia. Also, because of the CKD, there is reduced production of erythropoietin, because this erythropoietin is synthesized in the kidney itself. As kidney is damaged, this erythropoietin is very poorly synthesized. That also causes anemia. Very commonly, these CKD patients, they do have low folic acid, low vitamin B12 level, low iron. These all things very commonly cause anemia. That is the reason why we always consider injection erythropoietin. That can be once a week or once a month or every 15 days till the HB hemoglobin reaches around 10 gram percent. So the erythropoietin resistance is also very common in these CKD patients. So anemia is very common. As we know, because of the next problem is osteoporosis. These patients very commonly have very poor appetite, very poor mobility. They don't do exercises. They are not ambulated, and because of the CKD, they have hyper uh, parathyroidism that causes significant bone resorption. There is hyperphosphatemia, that is, the phosphate levels are increased in the blood, which all makes significantly lower density of the bone. So because of this poor mobility, ambulation, poor diet, cachexia, anemia, these all reasons markedly reduce the density of the bones, so they have increased risk of osteoporosis as well as increased risk of fractures, which is very commonly seen in those patients who have CKD, means those patients who have increased levels of creatinine, which keep on increasing. The eighth thing is hypertension. As we know, kidney filters blood. So this is all blood which is filtered by this kidney, so that the volume of the water which was present in the blood is reduced. Now this kidney is not at all filtering. So as kidney is not filtering, whatever food, whatever liquid the patient is taking, it is simply going into the blood, but the kidney is not filtering. So kidney is not filtering this fluid from the blood. So basically this is stopped here. So whatever the patient is taking, it is simply coming in the blood, but it is not going outside the blood. That is the reason why there is accumulation of the fluid in the blood vessel, and there is increase pressure on the blood vessels, because this fluid from the blood is not getting out, because urine production is markedly reduced. So these patients significantly continuously uh, develop increased pressure on the blood vessels from inside. So there is increased vascular tone. So automatically these patients will have hypertension. So persistent hypertension, there are two things. One is Because of the persistent hypertension, these patients very commonly develop left ventricular hypertrophy. And the second thing is, these patients usually don't respond very well to antihypertensive. There are so many drugs like ACE inhibitors, ARBs, aldactone. Such medicines are usually contraindicated for hyperkalemia risk. So we have to use cilnidipine or amlodipine or moxinidine or prazosin, these medicines to reduce the blood pressure. So hypertension very commonly occurs in patients with increased serum creatinine, and it is very commonly a resistant hypertension which needs multiple medicines, and these patients very commonly have the left ventricular hypertrophy. So shortness of breath, accelerated hypertension, hypertensive urgency, hypertensive emergency, these are very common problems in these patients, and these patients very commonly get admitted at any point of time, maybe early in the morning, for shortness of breath, and they may need ventilator for some time. Ninth thing is edema. As I told, this blood is filtered. So this blood is all made up of fluid only, water only, apart from some cells. So these kidneys filter this fluid and they make urine. So as these kidneys function less, so less urine is produced. So less water or fluid is removed from the blood. So automatically there is more fluid in the blood. More fluid in the blood means this more fluid will be accumulated everywhere in the body. So we very commonly see accumulation of fluid, that is edema, on the face, on the legs, up the abdomen, on the in the abdomen like ascites, in the pleural cavity as a pleural effusion. So anasarca edema is very common in those patients who have raised serum creatinine. Second thing is hyperphosphatemia. As I told, increased serum creatinine means poor kidney functioning. There is increased PTH level, hyperparathyroidism, that is secondary because of the CKD, which increases the resorption of calcium, increases resorption of calcium and phosphate. So there is increased phosphate in the blood, which has to be treated. LVH, as I told, that because of the persistent refractory hypertension, there is more and more pressure has to be generated. That is the reason why these muscles of left ventricle, they get large and large size. So these patients develop LVH and left ventricular hypertrophy. This hypertrophied muscle, it is very difficult to relax, because suppose this is the LV muscle which is smooth, and this is the muscle which is hypertrophied. Just see, this is all hypertrophied muscle. So this can relax very easily, but this cannot relax because this is so tense and so tense. So diastolic dysfunction is very common. Diastolic dysfunction is very common. Diastolic hypertension is very common, and this diastolic hypertension continuously increase the pressure in the left ventricle at the end diastole, that causes patient to have continuously or persistent shortness of breath even at rest or even with minimal exertion. So this is very important, which markedly reduces the ambulation of the patient, which markedly reduces the quality of life of this patient. The next thing is chronic inflammation. As we know, this is CKD. So it is chronic kidney disease. Chronic means it is all inflammatory disease. So this CKD causes reduced appetite, reduced vigor. These patients do very common have depression. They are malnourished. Their skin is very poor. Their hairs are very poor. They don't really feel good. Their muscle quality is very poor. So they cannot mobilize very well. They cannot dance. They cannot sing. So these problems very commonly happen if the CKD is not very well treated. If these patients are put on hemodialysis, or the creatinine is controlled at that point of time, at every point of time, then that can markedly improve the quality of the life of the patient. Now, heart failure, as I told, LVH is very common. Hypertension, LVH, diastolic dysfunction, these problems are very common with CKD patients. whenever there is increase in serum creatinine, as creatinine keep on increasing, the patient simply lands in more and more progressive kidney disease, and this ultimately causes hypertension, left ventricular hypertrophy, vascular dysfunction. It markedly increases the risk of heart failure, as well as markedly increases the risk of myocardial infarction, and it increases the risk of hospitalization of the patient because of the heart related element. The next thing is stroke. As we know, these patients have markedly increased hypertension, LVH, chronic inflammation, edema. They have markedly increased risk of intracranial hemorrhage because of uncontrolled or resistant hypertension. Or this, as these patients have heart failure, chronic inflammation, there is increased risk of thrombosis also. So these patients very commonly have multiple small ischemic infarcts or multiple ischemic strokes. So this is very common in the, patients who have increased serum creatinine to have. Cachexia, as I told, because of the inflammation, because of so many factors, they have reduced muscle mass, they have reduced fat mass, they have reduced, they have very poor food lifestyle, they have malnourishment, and so on. Neuropathy and retinopathy is very common. Neuropathy because there are because of the malnourishment, because of the inflammation, because of these multiple hospital admissions, multiple medicines, because of the increased risk of infections. These patients get so many antibiotics, so many medicines that also markedly reduce or markedly damage the almost each and every nerve of the body, particularly the lower limbs, upper limbs. That is the reason why these patients very commonly have tingling, numbness, pain, burning pain. So neuropathy is very common. The same way, because of the LVH, inflammation, cachexia, chronic inflammation, these patients have very commonly have retinopathy, so they very commonly have reduced vision or blurry vision, which is very common in those patients who have increased serum creatinine, landing them into CKD. One more interesting or important thing is acute kidney injury. Now, this term is very common in hospitals, we must know. So, to call it as acute kidney injury means the kidney which was good or maybe which was damaged, but suddenly it has received a trauma or injury. How can we say? We can say that on the basis of serum creatinine. It has total three definitions. So first is increase in serum creatinine by 0.3 milligram per deciliter. So if some patient has creatinine of 1.5 at the time of admission, and after 24 hours or 48 hours, if you see after 24 hours, if you see that there is rise in serum creatinine by 0.3, so if the patient's creatinine comes 1.9, we will call it as AKI. So rise in serum creatinine levels by more than zero point 0.3 milligram per deciliter, we call it as acute kidney injury. If this rise in serum creatinine is by more than 50% from the baseline within 7 days, we also label it as AKI. So if the patient has suppose creatinine of 2, and within 7 days, if the patient's creatinine goes to suppose 3.1, so the 50% of the 2 is 1. So if the creatinine goes from 2 to 3 or more than 3, uh, within 7 days, then we'll label this as the patient has acute kidney injury. So rise in serum creatinine by more than 50% from the baseline. So if the patient's creatinine is like 4, and if it is the 50% of the 4 is 2, so if the serum creatinine goes from 4 to 6.2 or 6.3, then when within 7 days, then we'll label it as acute kidney injury. And the third criteria for AKI is if the urine output of a patient is less than 0.5 ml per kg. In short, if the urine output of the patient is half the weight for consecutive 6 hours, we'll label it as acute kidney injury. So if someone's weight is 80 kg most of the patients do have this Foley's catheter. So if the patient's urine output is less than 40 ml for consecutive 6 hours, we can label that this patient has acute kidney injury. So the underlying fault, which can be some medicines like AC inhibitor or ARB or NSAID or antibiotics or drug overdose or sepsis or dehydration. Whatever is the cause for this acute kidney injury has to be treated, and we have to make sure that this problem gets reverted. So this was kind of a short overview regarding creatinine. We'll again come with some other interesting topic. And thank you. Don't forget to like and share and subscribe. Thank you.